I wanted to first talk about my journey, about how I got into social work. So when I was a social work student, I wanted to work with children. So I studied in Chennai, the Madras School of Social Work, and I was very particular about working with children and families. So I started working with children and families, and I finished my PhD, and then I had children as soon as I graduated from my PhD program. And I could no longer see myself working with children because that would be too much children at home and at work. So I started working with postpartum couples. And my intention was to just offer support for postpartum couples about parenting, about relationship. But then sexuality kept coming up so much. And I felt really not trained, ready to do this. So I went and got trained in couples therapy and sex therapy. And I started teaching and working with couples about sexuality. So I started practicing in a group practice. And then I was invited to teach at a medical school. There was a couple and family therapy program, and I was encouraged to teach sex therapy. Enjoyed the experience. And then I started consulting for the MS Foundation. See, now once you study sexuality, then everybody wants you. And as soon as I finished my presentation, I could not leave because they just swarmed towards me. And they all needed time, so they were very respectful of each other, so they allowed each other to, kind of speak to me privately. And they had so many questions, and there were so many emotional stories I heard about what was wrong and how they were not getting help from anybody, and the information that I gave them was very useful. Can you give us more information? Can we have your phone number? Can we contact you? I was overwhelmed. So I walked in thinking it would be just any other lecture that I was going to give on sexuality. And then I realized this is very important. This is needed. So as soon as I finished the talk, as I was leaving the conference, one of the representatives of the Young Survivors Coalition, this is a coalition, it's an international coalition that serves women under 40 diagnosed with breast cancer. She pulled me and said, "I would like you to speak at our conference in Orlando. Can you come in February?" I said, "Sure." So I was asked to do a keynote. I was completely unprepared because, first of all, I was suffering from a lot of survivor's guilt because I was sort of close to 50 when I was diagnosed, and I was going to speak to women under 40. And I was right to be apprehensive because there were 700 women in the big auditorium, and I was doing a keynote, and most of them were under 40 and had small children. They were carrying babies. Some of them were in their 20s and going through the metastatic. They were going through chemo and were wearing different headdresses. And it was a privilege to be able to give that talk. And then I did a breakout session with a group afterwards, a smaller group, on the specifics of how to deal with sexuality after cancer treatment, because the sexual side effects of cancer treatment is usually not talked about. And so now I have, since my diagnosis, I've done about 21 presentations to different cancer survivorship groups. And this includes prostate cancer survivorship groups. And sometimes it's a mixed group of cancer survivors. I've spoken for American Cancer Society, Young Survivors Coalition, Living Beyond Breast Cancer. There's an organization for Unite for Her. They have me on a contract. So I go on a regular basis and do my groups with people who come in. So they serve, that organization serves breast cancer survivors and ovarian cancer survivors. So you can see how one talk led me towards in a direction that I didn't expect to go towards. So, and then I got involved in doing a research study, and I will be presenting my findings here to show you why it is really important for social workers to be involved in sexual health. So, breast cancer is one of the most common cancers. and it's diagnosed among women worldwide, and 2 million cases of breast cancer was diagnosed in 2018. And there will be 268,600 cases of breast cancer diagnosed in the US in 2019. So quite a big number. So 1 in 8 women will be diagnosed in the US with breast cancer. And 1 in 7 women in Australia. I was really surprised by the number. So it is a very common health condition. So survivorship has really improved over time. So breast cancer is no longer a death sentence. So most breast cancer survivors, if detected early, will survive. That is why we need to think about survivorship, because some of these people will live for a long period of time. So they need information on relationship and sexuality and how to survive well. So 5, 10 to 15-year survival for women diagnosed with invasive breast cancer in the US is 90% for the 5-year survivorship, and 10-year survivorship is 90%, 83%, and then 15 years, 80% will survive. So that's a huge number. So you're going to see a lot of cancer survivors in your practice. So you'll have to offer them a full slew of services that includes sexuality information. So our study aim was to study the sexual concerns of breast cancer survivors in various stages of treatment, and then to document the extent to which these women were seeking information from healthcare providers, and then to document the sources where they were getting this information from, and to explore the relationship challenges and sexual satisfaction. So those were our goals for the study. And my co-researcher, by the way, was Dr. Linda Hauser from the Social Work School. And so we did a cross-sectional study. It was an online survey, and we had multiple choice questions and open-ended questions. So following every multiple choice theme, we had open-ended questions so people could type in their responses. And 95% of the respondents chose to answer the open-ended questions. They were really eager to share information with us. And so these were women 18 or older. They should identify as women. So this also included trans women if they wanted to participate, able to complete an English language survey, and then they were diagnosed at some point with breast cancer. So we recruited using my contacts because I was doing volunteer work for Living Beyond Breast Cancer and Young Survivors Coalition, so it was really easy to get a pool of respondents. So we posted on their website, and when I went to conferences, I handed them cards with our survey link so they could go and take the survey. And then we also used Facebook, LinkedIn, and Twitter. So we used descriptive statistics to analyze the data, and then we did some qualitative thematic coding as well. So the demographics was not as inclusive because it was an online survey. We really did not have control over the diversity of the samples. So most of them were highly well-educated, mostly white, and mostly straight or heterosexual, and they were married. And most of them had household incomes of less than $100,000. They were, upper class individuals. So it is not a generalizable sample. So 56%. So we also had some people who are middle class and lower middle class. So 47.1% were currently receiving treatment. So they were talking about their treatment and the side effects they were having as they were going through treatment. Or some of them had received treatment and no longer receiving treatment. I call chemotherapy as a gift that keeps on giving because once you get chemotherapy, the oncologist will not tell you what is going to happen to your body. But then when you go for yearly physicals, other physicians will tell you, oh, did you have chemotherapy? Oh, that explains. Your pancreas is probably affected. Oh, you are going to probably have this sun allergy. The dermatologist, so you'll probably have sun allergy because you had chemotherapy. So you'll keep getting these gifts throughout your lifetime. So, those individuals who have stopped receiving treatment are still experiencing side effects, many different kinds of side effects. So the treatment types that most of them were receiving, chemotherapy is one of the most common treatment type, hormone therapy or endocrine therapy, and radiation therapy, and then a lot of them were getting mastectomy with reconstruction. So very interestingly, when I work with the younger women choose not to have reconstruction. So a disproportionate number of younger women under 40, choose not to reconstruct, which is a very interesting trend, and I would love to look at it more in a pointed way. So what did we find out about body image? So body image is something that cancer survivors talk about all the time. So most people think, oh, they're losing their hair. Are they going to be talking about their hair loss? You know what most cancer survivors talk about? They talk about the loss of eyebrows. It's not about the hair because you can always wear a wig. It's about losing eyebrows because it makes you look completely different. So those are nuances that you wouldn't know if you did ask them about how do you feel about your body now. So we found that 74% told us that their bodies changed a lot. And so these were some of the qualitative comments we got. I felt sexy before and I do not now. It's just that my body and I feel no sexuality in it or with it. I won't even look at myself in the mirror. This is very painful to read. I have been carved up and I have vaginal atrophy. If you had told me that this would happen to me in 2009, I would have said, let me die. So this is just a sample of some of the comments we heard. Next one. So the theme that we got about the body was body betrayal. I took such good care of myself and my body let me down. And you see all these people smoking and drinking and going to parties, and I am the one who ended up with cancer, and I'm the healthy one, and I used to do yoga, I used to drink my green juice, and look what happened to my body. So that was the theme that we picked up over and over again. I cannot trust my body. I can feel great and have metastatic cancer. I can feel terrible and chemo is working. I did everything I was told and cancer came back. So the betrayal was a theme that came up with people who were not only diagnosed once, but were diagnosed again. And sometimes if the cancer is diagnosed again, it could be metastatic and they may live longer than people lived 20 years ago, but they will eventually die of the disease. So sexual difficulty was reported. 65% reported sexual difficulty, discomfort with sex, and pain from sexual activity. So we saw a huge number of themes around sexual activity. So several of them reported feeling self-conscious. So it was because of the scars, because of the weight gain, because of the hair loss, loss of eyebrows, and inability to lubricate on their own, lack of arousal, lack of desire. So they felt disconnected, they felt dissociated from their body because even if the reconstruction was perfect, people felt disconnected from the new breasts because it had no sensation. And some people refer to themselves as Freddy Krueger. They were like, they had terms to describe their body, which was, not in keeping with how they perceived it before. Pain was a very important theme because chemotherapy causes vaginal dryness and vaginal atrophy, and chemotherapy and hormone therapy can result in menopausal symptoms, which also leads to vaginal dryness and symptoms that cause sexual pain. Numbness was reported by many people, and most people whose arousal started with nipple play were very disappointed because the nipple was completely disconnected from their sensory experience. So numbness was also identified as a problem during sexual activity. And rejection from partner. This is not unusual. It is actually very common. And most often, after I finish my talk, there would be a couple of people who would hang back and wait for me to be done with everybody else, because they were the ones who were talking to me about the rejection from partner. What do I do? My partner no longer wants to touch me. My partner no longer wants to look at me. So when I work with couples, I usually tell partners, the best thing you can do for your partner is to look at them. Do not avert the scars. Do not avert the bloating or any other burns from radiation. Look at them, touch them, and help them accept this. Help your partner accept it. Because if you don't look at them with acceptance and validation, your breast cancer survivor partner is not going to accept it either. So that is the gift you can give your partner. And celibacy, some single women who were interviewed, who took the survey, talked about not wanting to date anymore because they did not feel comfortable presenting themselves to somebody new. So, and during the Young Survivors Coalition conference, this was the most common question that I got, and I was always prepared for it more and more with each time I heard the question. How do I put myself on a Match.com? How do I represent myself? Do I say I have cancer? Do I say, I had metastatic cancer? What do I say? I say, if you have psoriasis, would you say, I have psoriasis and I am a school teacher and whatever? You wouldn't do that. So I always tell my young people or even older people who are dating, put cancer in its place. It's not you. You're not cancer. You are a teacher, a mom, an artist, a traveler, all these things, and you had cancer. Can you put that on your dating website, that you're all these wonderful things? And perhaps you can bring up cancer on your second date. Let them get to know you as a person, who's exciting, interesting, and fun, and has a lot of things to offer. And then you can, talk to them about it. So that is my take, but there are other sexologists who have other belief systems, but I think mine is superior. So sexual activities, I cannot stand to have my partner touch my breasts. Because of everything, I had everyone and their brother touching it. This is a very common theme because physicians don't often ask before they, they sort of say to you. So we have some medical students waiting outside. Do you mind if they could come in and watch your reconstruction? So, you say, okay. I mean, what do you say? He's a physician. He did the surgery. Fine. I have a friend who had her breast reconstructed, and she said, it would be great when I pull up my bra if just people would just throw me at least some beads. Can people just throw, so I don't know if you know this, but in Mardi Gras in New Orleans, when you go on a parade, if you show your breasts, then people will throw beads at you. So she said, hey, at least these medical interns could just bring some beads and throw it at us when we're pulling up our bras. So that doesn't happen. So this was for radiation, scans, feeling for lumps, etc. So you just go to different people, just keep pulling up your bra. To me, they are no longer a part of my body for sex. They are something that tried to kill me. The only discussion about sex was a warning not to get pregnant. I think to myself, you have to have sex first for that to happen. I'm not having sex. Don't tell me not to get pregnant and then not talk about sex. They were very quick to move me out don't take time to ask how I was doing emotionally. So they just, physicians or even nurse practitioners sometimes don't talk about it. But nurse practitioners are actually the leaders in, talking about sexuality in the United States and Canada. So 89.7% reported very severe sexual difficulties, and some responded discomfort of sex, and 58.6% reported pain with sex. So, and this is not pain that you can just power through. One client of mine told me that it felt like she had glass shards in her vagina when she was having penetrative sex, and that is not okay. So if they power through it, I tell them not to power through it, because if they power through it, then they're causing lesions and bleeding. So I usually tell the groups I work with, if it's bleeding, it's not right. There's something wrong. You really need to stop. So do not do it for your partner. Do not do it to save your relationship. Do not do it because you want to keep this person you're dating. Because if they don't understand, it's not worth staying in that relationship. So the themes were pain and discomfort. Treatment is giving vaginal atrophy, a terrible expression. Vaginal sex is extremely painful, even with a lot of lube. Sometimes physicians sometimes give really bad advice. One physician told a person who was experiencing pain, drink a glass of wine, you'll be fine. These are very popular suggestions given by physicians and nurse practitioners. Drink a glass of wine and get a hotel room and wear your robe with nothing inside, and it'll be very exciting, so you'll have sex. None of these work when you have vaginal atrophy. So I wish they wouldn't give this bad suggestions, or use lube, use coconut oil. So yeah, these are all, and coconut oil is not even good, by the way, if you're having vaginal atrophy, because it actually makes things worse. So my reconstruction failed, and as such, I don't feel fully functional during sex anymore. Lack of self-confidence in my appearance, which has led to a loss of relationship with my partner. I don't feel attractive enough to be able to find a man who would want to date me. This is a very common theme. He doesn't deserve this. We are tired of alternate activities, because sometimes therapists will talk about sexuality, but they'll say, well, penetrative sex is not that important. Can you try alternative activities? Which is a great suggestion, which I hope most therapists would do. But then some people say, I've been doing this for 5 years. Can I try something else? Can you just help me, treat what's going on so I can actually have penetrative sex because I enjoy it? So after 4 years, most of the time I'm already asleep from medication. It just sucks. He's a saint. So there's a feeling of guilt that I'm not giving enough to this relationship. Will this relationship survive? And sometimes penetrative sex is important for some individuals. And I remember recently I gave a talk in Pittsburgh, and the 60-year-old couple walked up to me and said the female partner was diagnosed with vaginal cancer. So they had to remove part of the vagina, and her vagina was really short, so she could not have penetrative sex. So her physician said, no penetrative sex at all. But there is a product now which is called O-Nut. And these are silicone rings you can fit on the penis, which makes the penis shorter for penetration. So this can be used also by people who enjoy anal sex, and if they have colon cancer or rectal cancer. So this couple was actually ideal for such a product, and I gave them this information. This is a brand new product, and I found out about it last year at a conference, sexuality conference. And so they may be able to have penetrative sex because it really, it can be used to reduce the length of the penis. So they were very excited to try it. So responses from healthcare providers. This is what is most important for social workers to understand why it is important for us to learn about sexuality, because we may be the only people who may be able to provide this information for our clients. So 38% reported that their healthcare providers never talked about sexuality. And 41% reported that they talked about it rarely. And 17% sometimes, and 4% said that they often talked about sexuality. So most healthcare providers are not talking about sexuality. After giving these toxic medications that are going to ruin their sex life and ruin their sexual bodies, they're not telling patients, look out, you cannot have vaginal intercourse without getting a proper assessment from a GYN. So please be careful about it. So I wasn't comfortable with my oncologist throughout, and I wouldn't even bring the subject up with him because they were not making themselves accessible, askable, as George Turner said. He stated that sex would be different and I wouldn't feel in the mood. So they're saying you may not be in a mood, but they're not saying your body is going to be completely devastated and you're going to need big time help. I never discuss it with my oncologist because we had bigger fish to fry. So this person was probably going through treatment at that time. So during chemo and radiation, nobody spoke about sexual side effects. I believe one pamphlet mentioned that spouses may have difficulties with the patient's body post-surgery. Spouses may have difficulties, but not them. I did ask the nurse practitioner about the vaginal dryness, and she suggested coconut oil. I also discussed it with my gynecologist, but basically there is no cure for my extreme lack of desire. Of course, desire cannot be fixed with a pill. Big Pharma is trying hard to provide a pill to fix desire disorders, but it's not going to happen because it is a combination of things. My healthcare provider is generally disinterested and dismissive of any sexual side effects like fatigue or pain. So I've never brought up sexual side effects as my experience with their treatment side effects discussions are disappointing. Because sometimes, physicians just say, I'm sorry, I can't help you. People tell me that, but I cannot do anything about it. Because medical schools spend 3 hours on sexuality in America, the United States. One of our students just finished her dissertation and learned that medical schools, but it varies because we have some medical schools that do have really, are taking a leadership position in educating physicians about sexuality, but most medical schools do not have a full curriculum in sexuality. When I brought up the topic of sex up, he told me that due to medicines I'm currently taking to treat my breast cancer, I can't get pregnant. She brought up sex and he says, don't get pregnant. Nothing further was discussed. I didn't push, and I think he would rather a nurse talk to me about sex, especially since he and I are the same age. So she's just, she's kind of making herself responsible for this. So mental health professionals, these are, therapists and social workers they speak to. Again, 37% never talked about it. So how often mental health professionals offered information on sexuality or side effects? And 35% very rarely, and 24% sometimes. The information they gave me was trite, like no one really understands our issues with sexuality are different from other patients. Say, take menopausal discomfort and multiply it by 1,000,000, said somebody. So one of the healthcare providers said, just take menopausal symptoms and multiply it by 1,000,000. That is really inadequate information. I think counselors are more concerned about how I view myself than how I think a guy sees me. Sometimes you may just have to ask open-ended questions. How do you feel about your body? How do you feel about your body when you're with your partner? When you ask these open-ended questions, then all the themes about their own sexuality comes out and how they're experiencing the sexual side effects. Most healthcare providers are clearly not addressing sexuality. And why are they not talking about sexuality? It could be because of personal inhibitions, because they have not been trained to get over their personal inhibitions, and negative sexual scripts. If they were told in their families that talking about sex is bad, they cannot ask questions about sex, then they themselves will not talk to their patients or clients And lack of training. So training includes didactic and experiential. So our training program includes an experiential part, which is called SAR, Sexual Attitude Reassessment, where we watch movies, we talk about sexual parts, we talk about our experience of watching the movie, how we feel activated, what activates us, what feels shameful to us. So as trained sexuality professionals, we go through this experiential program. So when someone is talking to us about sexuality, we do not get activated and embarrassed. We know how to keep a straight face, and we know how to get to the bottom of the issue without our own inhibitions getting in the way. And lack of support from their work environment. Most physicians don't have the time. I mean, I don't blame, they don't have the time to ask more questions other than the symptoms. And myth that clients will bring up sexual issues on their own. So studies are showing that patients will not bring up sexual information on their own unless you bring it up first, because they're waiting to see if you will bring it up. If you don't bring it up, they will protect you. And if they bring it up and you look embarrassed, they will shut down immediately. Or if you give them a trite comment, they will not expand on their concerns. So sexuality training needs to be integrated into the curriculum, which is what we believe in, and I know it works. And SAR training is really important. So according to ASECT, our certifying body, we need 10 hours of experiential training. So this includes videos, exercises, small group discussions, large group discussions on a variety of sexual behaviors to help us to desensitize us, to reduce our anxiety, so we can go out and work with our clients. So I'd like to talk to you about the Plicit model. The Plicit model is something that all of us can use. It's a very simple model. And even though it was first written in 1976, I think it's still very relevant. So it's usually used by educators, counselors, and therapists. The model provides four levels of approach. So each letter or pairs of letters means something. So I will just have the next slide, which explains it more. Permission giving. Just letting clients know that they can talk about sex is great, would be amazing, because it will give them a place to talk about things that concern them. So that is the first level, and anybody can do that. Anybody can give permission to clients to talk about sexuality. And limited information. Sometimes clients will come to me and think that unless their female partner has an orgasm during intercourse, there's something wrong with the way they're having sex. So just giving them limited information, telling them that 60% of women cannot have orgasm through intercourse alone, and then they don't come back. So that is the simple. Sometimes it's just that. They call me and they tell me, this is my main concern. I'm like, well, just so you know. And then they just do not need to come back. So giving them limited information, just so educating ourselves about sexuality is very important, because we can really enhance their life by providing them with information. Specific suggestions, like the 60-year-old couple who came to me because they were not able to have intercourse, and she had vaginal cancer, and her vagina was really short. Giving them this information about O-nut, and if with people with muscular multiple sclerosis who do not have muscle tone, providing them information about what's called a liberator, a pillow that aids with sex, providing them information about lubricants, vibrators. There are many tools now that can enhance sexuality. So learning about it and keeping this information with you and providing this information in and of itself can be a big gift. So this is why it is really important to learn about all the options. And intensive therapy is usually done only by sex therapists. So this treats complex individual and relationship issues, such as sexual trauma, sexual shame. So these are the different levels of treatment. And I would say that with really some training, we can at least do the first 3 levels. So I think I've gone through it. So this is how social workers can fill the void that is due at least the first 3 levels, and then giving them permission, and then referring them to sexual pain specialists. You know, have this information ready, a referral list. So if you cannot treat sexual pain in any other way but through referral, then by all means find the sexual pain specialists in your city and keep a list of them and have a relationship with them. And then educational handouts for patients and their partners. I think this is it would be a gift to give information to patients and their partners. I remember when I used to treat postpartum couples, there's a myth in the medical community that women can have sexual intercourse after 6 weeks, which is really a myth, and most people are not ready. So just telling their partners that is a myth, it doesn't work that way, really ends many relationship issues. So just giving them a handout about research on it can be very helpful to these couples. And information sessions for medical professionals, grand rounds, brown bag lunch discussions. I do grand rounds for physicians because this information needs to be given, and social workers can absolutely fill the void. I do grand rounds all the time to OBGYNs, to oncologists, to other healthcare providers. They really need this information, and they pay me for it. Medical schools pay for this training. And engaging in research and scholarship activities related to sexual adjustment of cancer survivors can also be a really good way to enhance the field. I think that's it.